Hello everyone, welcome back to my channel. My name is Dr. Millie Dokra, and today we will be talking about a very important class of drugs known as the opioids. And actually, before we start our lecture, I would like to mention that if you hear a very overzealous bird in the background, that is just a very excited parrot that is owned by one of my neighbors. So yeah, try to ignore that, but he's very loud. Anyway, so today we will be talking about opioids. Opioids are a very important class of drug. So they are a vital part of providing analgesia. And as you know, analgesia is a very important part of balanced anesthesia. You cannot have balanced anesthesia without analgesia, which is the loss of pain sensation. A lot of the times the patients are actually not really afraid of the operation or the surgery itself, but they are more concerned about the pain in the post-operative period that they are going to experience. So it is our job as anesthesiologists to not only provide unconsciousness during anesthesia, but also to relieve the patient of their pain, which is called analgesia. And opioids are a vital part of providing the analgesic component of anesthesia, and also often forms the foundation of post-operative pain management. So they are extensively used not only in the intraoperative period, but also in the pre-op period as a means to allay anxiety and provide preemptive analgesia, during the intraoperative period naturally to provide intraop analgesia, and also in the post-operative period to provide post-op analgesia. In addition to taking care of the acute post-surgical pain or post-operative pain and many other types of acute pains, opioids also form part of other non-operative pain in non-operative settings such as trauma, right? Or sometimes even chronic pain. Although there are a lot of differences between acute and chronic pain, and sometimes the chronic pain does not really respond that well to opioids, but nevertheless, opioids do also have a role in chronic pain management, cancer pain management as well. So, opioids suppress pain by targeting multiple sites throughout the nervous system, including the action in the brain, spinal cord, and the peripheral nervous system. So, if you guys want a separate lecture regarding the various pain pathways that we have in our body, do let me know so we can talk about pain pathways and pain physiology in detail in a separate lecture. But right now, I just want you to focus on just the very basics of the pain pathway. So, if you take a look at this diagram, here you can see what the pain pathway actually looks like. So, pain pathway is comprised of three orders of neurons. So, there's the primary afferent neurons, or the first order neurons, the second order neurons, and the third order neurons. The first order neurons are comprised by these neurons, which have their cell bodies in the dorsal root ganglion of the spinal nerve. Now, they are going to have a peripheral process, and they're also going to have a central process. The peripheral process actually ends in the nociceptors. Nociceptors are specialized receptors that have the ability to sense pain. So they pick up the painful stimuli, and then those painful stimuli will be transmitted via the central process of the primary afferent neuron, which will terminate in the dorsal horn of the spinal cord. And from the dorsal horn of the spinal cord, you will have the origin of the second order neurons, which, as you can see here, cross over to the other side. And this crossover is known as decussation. Once they cross over to the other side, they travel up the spinal cord in something known as the spinothalamic tracts. There can be lateral spinothalamic tracts and anterior spinothalamic tracts. There are other ascending pain pathways as well, but the most important ascending tracts that carry the sensation of pain is the spinothalamic tract. And as you can see, the second order neurons travel up the spinal cord, and finally they are going to end up in a very important structure which is known as the thalamus. So this is the thalamus, and it acts as a relay station. And from the thalamus, your tertiary order or third order neurons originate and ultimately end in the somatosensory cortex. Now, this kind of a route of the pain pathway, which ends in the somatosensory cortex, will be responsible for the sensory discriminatory component of pain. So pain actually has two components. We have the sensory discriminatory component, and we also have motivational affective component. Sensory discriminatory component means that this will essentially tell the person where exactly the pain is originating from and what to do in order to get away from that source of pain. So, the somatosensory cortex will be able to delineate whether the painful stimulus is coming from the hand or the foot or the torso or the back. But the motivational affective component is responsible for the associated symptoms along with pain, such as fear, anxiety, emotional upheaval, and autonomic instability or autonomic responses to pain. All of that is responsible or is mediated by the motivational affective component of the pain perception. So as you can see, as the pain pathway is ascending up the spinal cord and ending in the thalamus, it has certain important connections along the way. Here you can see it is connecting to the amygdala, to the insular cortex, to the parabrachial nuclei. All of these are part of the limbic system, right? So, or rather, amygdala is part of the limbic system, but all of these associations are going to be responsible for the associated symptoms. So, whenever the person experiences pain, they will not only know that where exactly their painful stimulus is coming from, but they will also have certain associated responses, emotional responses to pain, such as crying or anger or fear or anxiety, right? And will also have autonomic responses associated with it. Similarly, apart from these connections to the limbic system, the ascending pain pathways also have important connections to this structure, which is known as the periaqueductal gray and the rostral ventromedial medulla. Right now, the PAG RVM system is a very, very important system, as we will come to know just a little later, because it is a very important site of the action of opioids. But suffice to say that PAG RVM system is the essentially the descending modulatory influence on the pain pathway. Right, so they are going to have certain descending neurons which will descend and go all the way up to the dorsal horn. They will interact and synapse with various interneurons, and they will facilitate or inhibit the transmission of painful impulses, thereby increasing or decreasing the level of pain which is being perceived by the animal or that is being transmitted along the pain pathway. So this is very, very important that you should keep in mind. A very basic kind of an understanding of how the pain pathway actually works. Now, these opioids are not something that is very new or novel in the field of medicine. Their remarkable beneficial effects, particularly their ability to provide pain relief or analgesia, as well as their toxic effects and their addictive potential, all of this have been known for centuries in the field of medicine. There is some confusion regarding certain terms such as opioid, opiate, and also narcotic. So people often get confused with these terms. Now, opioid actually is a term that is given to any compound, whether it be natural, synthetic, or semi synthetic, that produces clinical effects by interacting with the opioid receptors. Whereas opiate refers to compounds that are specifically derived from opium or are chemically related to morphine, structurally or chemically related to morphine. Those will be termed as opiate. And narcotic is a general class of drug that blunt sensation and depress consciousness. For example, let us take two examples. We have thebaine and we have fentanyl. So we know that thebaine is a opioid because it interacts with the opioid receptors. Similarly, fentanyl is also an opioid because it also interacts with opioid receptors. So the requisite for any drug to be called an opioid is that it should produce clinical effects of analgesia and whatnot by interacting with the opioid receptors. Then it can be called as an opioid. Opiate, on the other hand, is a drug that is directly derived from opium. For example, thebaine is derived from opium, but fentanyl is not. Fentanyl is a synthetic, completely synthetic opioid. Therefore, you cannot term fentanyl as an opiate. It is an opioid, but it is not an opiate. Thebaine, on the other hand, is both an opioid as well as an opiate because it is derived from opium and it also structurally resembles morphine. In fact, it is known as a morphinian derivative. And both of them can be classified as a narcotic because they both blunt sensation and depress consciousness. So there is some confusion regarding these three terms, so I hope this kind of clears it up. Now, the term opium itself was derived from the Greek word opos. And opos meant juice. So opium was actually derived from the juice of the opium poppy plant, Papaver somniferum. Now, I won't be going into the history of opioid use in medicine, but suffice to say that it was very well known from like Theophrastus of ancient Greece through to the Middle Ages. Everyone knew about the analgesic effects of opioids. Opium actually consists of about 20 different alkaloids, out of which the most active and potent one was isolated by a scientist called Sir Turner in 1806, and he named the most active compound morphine after the Greek god Morpheus. He was the god of dreams. Since then, a lot of semi-synthetic and synthetic opioids have been developed with varying potencies and pharmacokinetics and dynamics. So now let us talk about the classification of opioids. So opioids can be classified in a number of ways. So first, you can actually classify them based on their origin. So based on the origin, they can be classified as natural, semi-synthetic, or synthetic. So drugs such as morphine, codeine, thebaine, these are all completely natural opioids. Semi-synthetic opioids include heroin, buprenorphine, hydromorphone, hydrocodone, and oxycodone. And synthetic ones, I'm sure you are familiar with butorphanol and all of the phenylpiperidine group of drugs such as your fentanyl, pethidine or meperidine, L-fentanyl, sufentanil, remifentanil, right? So all of these are, even your pentazocine, which is Fotuin. So all of these are synthetic opioids. So you can classify them based on their origin. On the basis of their structure, opioids can be classified as phenanthrene derivatives, also known as morphinian derivatives. So as the name suggests, their structure closely resembles that of morphine. So drugs such as obviously morphine will come in this, codeine, thebaine, even butorphanol, buprenorphine, and also certain antagonistic drugs that have the clinical effect that is opposite to morphine. They would still be called as phenanthrene or morphinian derivatives because their structure resembles that of morphine. It is just that the configurational changes and intracellular signal transductions that they produce are completely different to that of morphine. But nevertheless, they also come under this category, such as naloxone and naltrexone. I'm sure you all must be knowing naloxone is the drug of choice for opioid overdose. So apart from phenanthrene derivatives, you also have phenylpiperidine derivatives. They are characterized by the presence of phenylpiperidine ring. If you watched my lecture on these neuromuscular blocking drugs, I talked about all of this, the phenylpiperidine and piperidine rings. So if you want to go ahead and take a look at that lecture, I will link it down in the description below. But these opioids are characterized by the presence of a phenylpiperidine ring in their structure. So examples include pethidine, also known as meperidine, and all of the fentanyls, L-fentanyl, sufentanil, and remifentanil. Then we also have benzomorphin derivatives, which only comprises of like one drug, which is pentazocine. And then finally we have methadone derivatives, also known as your diphenylpropylamine derivatives, which obviously has just one drug, which is methadone. And finally, you can also classify opioids based on their action at the opioid receptors. So based on the action that they produce on the opioid receptors, they can be pure agonists at these receptors, or they can be agonist, antagonist. So they might be agonistic at one type of opioid receptors, such as, let us suppose, mu receptors. We will be talking about the classification of opioid receptors and the different types of opioid receptors that are there in a short while. So some of the drugs might be agonistic at the mu receptors, but this very same drugs will have antagonistic action at the kappa receptors. So you can have drugs with mixed agonistic antagonistic properties. Then you could also have partial agonists that have agonistic activity but not nearly as strong enough agonists as some of the pure agonists such as morphine. And then you also have pure antagonists. So pure agonists include naturally morphine and fentanyl, sufentanil, remifentanil, alfentanil, etc. Agonist antagonists include pentazocine. So Fortwin is actually an agonist antagonist drug. So it has a agonistic activity at the kappa opioid receptors, but it has an antagonistic activity at the mu opioid receptors. That is why sometimes it can actually, if you have already given morphine to the patient, or let us suppose if you have given fentanyl to the patient and you give pentazocine to that same patient, then the analgesic effect of fentanyl will be counteracted by the blocking ability of pentazocine. So it can have analgesic or opposite analgesic effect to fentanyl and can decrease the analgesic potency of fentanyl. So apart from pentazocine, nalorphine is one drug that has mixed activity, and nalbuphine is another drug. Then we also have partial agonists such as butorphanol and buprenorphine and codeine. And finally, in pure agonists, you have naloxone, naltrexone, nalmefene. So this is how you can actually classify opioids. A very important aspect of understanding how opioids work is to understand the receptors that they interact with. So now we are going to talk about opioid receptors. Broadly speaking, so just try to keep it very simple. Broadly speaking, there are three types of opioid receptors. We have the mu receptors, the kappa receptors, and we have the delta receptors. Now, why are they so named? They are so named because when they were identified, when they were described, they were described in 1970s, and by 1990s there were DNA sequences, complementary DNA sequences that were being isolated and that were being found that corresponded to these opioid receptors. But the opioid receptors were first described in 1970s. So they did some pharmacological studies and they found out certain ligands that bound to these specific opioid receptors. Now, depending on the original ligand that was described to be binding to these receptors got their names. So in case of mu, the original ligand was morphine. In case of kappa, the original ligand was ketocyclazosine. And you would be actually surprised to note that it was not that the delta receptor that was initially described, right? Rather, it was the sigma receptor that was described first. So instead of mu kappa delta, as we, if you ask someone today what are the three opioid receptors, invariably they're going to say mu kappa and delta receptors. But the initial three receptors that were described were the mu receptors, the kappa receptors, and the sigma receptors. The original ligand for the sigma receptors was the SKF10047. Now, granted that sigma receptors are no longer classified as opioid receptors. They are no longer considered to be opioid receptors. Activation of sigma receptors was associated or was found to mediate hallucinations, dysphoria, and seizures, coma, respiratory depression, and all of the bad effects of opioids. But now they are no longer classified as opioid receptors because in the complementary DNA sequences, no DNA sequence was found to correspond to sigma, or rather no opioid DNA sequences associated with other opioid receptors was found to correspond to sigma receptors. So they are thought to be entirely different sort of receptors. They're no longer considered to be opioid receptors. Additionally, then delta receptors were described, and they were named delta because they were first isolated from the mouse vas deferens. So D for deferens, D for delta, I suppose. So that is how the opioid receptors were described. Now, opioid receptors are actually present all over the central nervous system and the peripheral nervous system. But there are certain important sites where opioid receptors are actually present in very, very high concentrations. So the highest concentration of opioid receptors will be found in the spinal cord, in the thalamus, in the limbic system of the amygdala, in the brainstem, specifically the periaqueductal gray and rostral ventromedial medulla, and also the peripheral nerves. Right? So these are the sites where opioid receptors are present in maximal concentrations, and these are the sites of action only where opioids act. The most important sites of actions would be that you should always remember is the brainstem, which mediates the supraspinal effects of opioids, specifically the PAG-RVM system, and also the spinal cord, the dorsal horn of the spinal cord. This is actually divided into 6 laminae. Right, so for example, if this is the gray matter of the spinal cord, just a very rough diagram, the dorsal horn, if I zoom in on the dorsal horn, then it is going to be divided into 6 laminae. This is the first lamina, second, third, fourth, fifth, 6, and so forth. In fact, there are 10 laminae that have been described, and the scientist who described them was called Rexed, and that is why they are all often called as Rexed's laminae, dorsal horn laminae. He described 10 laminae, and 5 or 6 of them are actually present in the dorsal horn. Now, the second lamina is very, very important. The second lamina is known as substantia gelatinosa. The first two laminae are collectively termed as the marginal zone. So opioids actually have a very important action on the substantia gelatinosa. Now let's talk about the endogenous opioid peptides that exist in our body, because our body did not evolve these receptors because we knew that later down the course of human evolution we will develop certain drugs that will be used as analgesics. No, our body itself produces certain compounds that innately bind to these receptors and produce the very same effects as produced by these artificially exogenously administered opioids, though not nearly to the same potent extent as the exogenously administered one. But nevertheless, we do have certain endogenous opioids present in our body. Now, there are 3 types of endogenous opioids. We have endorphins, enkephalins, and dynorphins. Now, these are actually derived from 3 precursor proteins. The first is the pre-pro-opiomelanocortin, right? So, pre-pro-opiomelanocortin. As the name suggests, it not only is responsible for the production of endorphins or like endogenous opioid peptides, as suggested by opio, it is also responsible for the production of melanocyte stimulating hormone, and ACTH. And naturally, the most important opioid, endogenous opioid that it produces would be beta endorphin. The second precursor protein is the pre-proenkephalin, also known as proenkephalin A or PENK. And the most important endogenous opioids that are produced by this peptide are the metenkephalins or methionine enkephalins and the leucine enkephalins or leuenkephalins. And finally, the third precursor protein is the pre-pro-dynorphin, also known as proenkephalin B or PDYN. And the opioids that it produces are the dynorphin A and dynorphin B. Now you remember the opioid receptors that we talked about: mu receptors, kappa receptors, and the delta receptors. Now the endogenous opioid at the mu receptors are the endorphins 1 and 2. Sorry. And the endogenous receptors at the kappa, and endogenous opioids at the kappa receptors are the dynorphin A. And the endogenous opioid peptides, the delta receptors, are the leu and met enkephalins. Now, opioid receptors as a whole have different physiological effects or pharmacodynamic effects in the body, from analgesia to respiratory depression to constipation to meiosis or pupillary constriction to mediation of addiction, tolerance, and also certain other effects that you might not expect, such as growth hormone release or inhibition of dopamine release, etc. etc. And these different opioid receptors have been implicated in different types of effects, which we will talk about later. But for example, mu receptors are thought to mediate. There are further mu receptors have been further divided into mu1 and mu2 types, subtypes. Mu1 receptors are thought to mediate supraspinal analgesia. They are thought to mediate the meiosis associated with opioid use. They are thought to mediate the bradycardia. They are thought to mediate hypothermia, urinary retention. Whereas spinal analgesia, respiratory depression, constipation, decrease in cuff reflex, and dependence and tolerance, all of these have been implicated with the mu2 receptor activation. Similarly, kappa receptors are thought to mediate supra and spinal and supraspinal analgesia, although not as effective as mu receptor activation. They also mediate constipation, sedation, meiosis, respiratory depression, dysphoria, hallucinations, diuresis, and delta receptor activation will also lead to spinal and supraspinal analgesia, but will also lead to respiratory depression. But the unique thing about delta receptors would be that its activation will also release an increase in the release of growth hormone, inhibition of dopamine release, and also modulation of mu receptor activity. Right. So, talking about just a quick word about dynorphins, as you can see, dynorphin A is the natural endogenous ligand at the kappa receptors. However, the analgesic role of dynorphin A, in contrast to endorphins, leu, and met enkephalins, is not very well established. We know that endorphins, alpha endorphins, beta endorphins, or endorphin 1 and 2, and enkephalins, met and leu enkephalins, they have been shown to be consistently associated with analgesic or anti-nociceptive properties. But dynorphins, the analgesic role of dynorphin A through its binding to the kappa receptors is a bit controversial. In fact, it has been found that dynorphin A is present in the dorsal horn, where it plays a critical role in the sensitization of nociceptive neurotransmission. It is also found that the levels of dynorphin A are increased in the dorsal horn after tissue injury and inflammation. So what does this mean? This means that dynorphin A also has some pro-nociceptive or pain-producing properties. And these pain-producing properties of dynorphin A are independent of its opioid receptor pathways and are thought to be mediated through bradykinin receptors. Therefore, dynorphin A might not be just might not just have analgesic effects via the opioid receptors, but it also might have some pro-nociceptive properties by its interaction with bradykinin receptors and subsequent sensitization of nociceptive neurotransmission. Recently also, there have been a new system of receptors that have been described. The same old receptors have been now renamed. For example, we have the mu receptors are now known as MOP receptors. The kappa receptors have been renamed as KOP receptors. The delta receptors have been renamed as DOP receptors, and a new analgesic system has also been found, another receptor apart from these normal three receptors, and that is known as the ORL1 receptor, which is known as orphanin opioid receptor like subtype 1. And the endogenous ligand at this opioid receptor is orphanin FQ, which is also known as nociceptin. In fact, it is found that nociceptin or orphanin FQ, so when these opioid receptors were being described, it was found, especially these newer ones, it was found that when they injected orphanin FQ or nociceptin in the spinal cord, there was analgesia. But when they injected the nociceptin, artificially they injected it in animal models in supraspinal centers, there was pain and pronociception was observed. So nociceptin, as the name suggests, it is producing pain, right? So, but it can also produce analgesia. Whether the animal shows analgesia or whether the animal shows pain in response to nociceptin action via the ORL1 type of opioid receptors depends on the underlying basal state of the pain in the animal. If the animal is already in pain, then the administration of nociceptin, especially in the supraspinal levels, will lead to more painful perceptions or facilitation of painful transmissions. Whereas if the animal already has basal state, has no pain, then the animal will be rendered analgesic or to painful stimuli. So further work is actually being done on these novel receptor subtypes of ORL1 and their endogenous opioids, and it was found that agents that had activating properties at the ORL1 receptors, they showed analgesia without showing the adverse effects of opioids such as respiratory depression, nausea, vomiting, tolerance. So naturally, if we develop a drug that can produce analgesia without the deleterious effects that are associated with other opioids such as respiratory depression, constipation, which limit the use of other opioids, that will be a very, very marvelous thing to have in the armamentarium of various physicians. So now just a quick word about the various genetic variations which can actually influence the opioid effect. Now we know that let us suppose we have a complementary DNA sequence within the genome that is going to produce a certain RNA which is then translated into a protein. Let us suppose mu receptor. Now, if we know that proteins are nothing but they are long chain of amino acids. So if there is any change in the sequence of these amino acids, that is going to cause a change in the structure of the mu opioid receptor. Now, the most common alterations that have been found in the mu receptor gene are the single nucleotide polymorphisms or SNPs. They are sometimes known as just SNPs. Now, the most common of these SNPs is the A118G mutation. Right. Now in this mutation, there is actually an A to G substitution at the 40th position in the amino acid chain of the mu opioid receptor. So this actually leads to the amino acids being substituted. So your asparagine is substituted by aspartate. Now this, when scientists found when patients had this type of single nucleotide polymorphisms, it reduced the analgesic effect or analgesic response to morphine. But it did not significantly affect the respiratory depressant effect of morphine, surprisingly. Right? It has also been implied or implicated that the opioid dependence and addiction might have to do with this A118 gene mutation, especially in Asian populations. Another result of this 118G allele may be that it can actually lead to differences in the anti-nociceptive potency of opioid analgesics. The other mutation that can affect the potency of opioids would be the C17T mutation. So just like the A118G mutation, which was happening at the 40th position, this happens at the 7th position of the amino acid gene. And this results in a substitution of alanine to valine. And this mutation has been reported to occur in a higher overall proportion in the opioid dependent patients. So it might have something to do with the development of opioid dependence. And the effects of C17T polymorphism on analgesic responses, however, is unknown. However, it has been suggested that this mutation may affect individual responses to opioid therapy and may also contribute to susceptibility to substance abuse. Similarly, we also have Val 158 MET polymorphisms. So this actually contributes to the differences in opioid consumption in patients who are being treated for chronic cancer pain. So patients with these polymorphisms will have higher opioid consumption rates than patients who do not have these polymorphisms. So a lot of the time, these single nucleotide polymorphisms that exist in the population might help explain why different people and different subsets of population respond differently to opioid therapy. Okay, so now let's talk about the intracellular signal transduction mechanisms of opioid receptors. We know that opioids bind to the opioid receptors, but how do they, what intracellular mechanisms are happening that cause them to produce analgesia? So we know that opioid receptors belong to the family of receptors known as G protein coupled receptors. We have talked about these receptors in previous lectures as well, but just to reiterate and review, G protein coupled receptors are special receptors that have 7 transmembrane serpentine looking domains. For example, if this is your lipid phospholipid bilayer, then it would look something like this. A G protein coupled receptor. Right. Now a G protein coupled receptor is actually coupled to G. What does G stands for? It stands for GTP activated protein coupled receptor. So in fact, in its resting state, a G protein coupled receptor looks something like this. On the intracellular side of the G protein coupled receptor, there is a GDP molecule and it has 3 subunits, an alpha subunit, a beta subunit, and a gamma subunit. Let us assume this is a calcium channel, a voltage gated calcium channel. And let us assume this is a potassium channel, an inwardly rectifying potassium channel. So the voltage gated calcium channel is going to allow the entry of calcium inside the cell, and the inwardly rectifying potassium channel will allow potassium to leave outside the cell. So what happens when an opioid comes and binds to this receptor? When an opioid or a ligand binds to this receptor, the GDP is replaced by GTP. Right? So instead of GDP, now we will have GTP. And the beta gamma subunit, they dissociate. Now this activated GTP alpha is going to be responsible for the physiological effects. Now, depending on the type of G protein coupled receptor, it is either going to stimulate the adenylyl cyclase enzyme or it is going to inhibit the very same enzyme. If it stimulates the enzyme, it is going to cause increase in the concentration of cyclic AMP. If it inhibits the enzyme, it will lead to decrease in the concentration of cyclic AMP. And these will further alter the level of protein kinase A. In the first case, it will increase the activity of protein kinase A. In the second, it will decrease it. This will cause phosphorylation of various proteins and leads to physiological effects, and this will lead to less phosphorylation and its corresponding physiological effects. Now, in case of GQ protein coupled receptor, so if the GTP alpha activated GTP alpha complex stimulates the adenylyl cyclase, the receptor is said to be a GS protein coupled receptor or stimulatory receptor. If it inhibits the activity of adenylyl cyclase enzyme, it is said to be a GI protein coupled receptor or inhibitory receptor. In case of GQ protein coupled receptor, they act via entirely different secondary messengers. Here we have phospholipase C enzyme, which converts phosphoinositol diphosphate into inositol triphosphate and diacyl glycerol. The diacyl glycerol stimulates protein kinase C, and inositol triphosphate increases intracellular calcium. Now, in case of opioid receptors belong to GI group of or class of G protein coupled receptor. Therefore, they inhibit the adenylyl cyclase enzyme. They cause reduction in cyclic AMP. They cause decrease in the activity of protein kinase A, and they also inhibit the voltage gated calcium channels, and they stimulate the inwardly rectifying potassium channels. All of these things are going to result in decrease in the excitability of the neuron. So you can very well imagine, if the neurons of the pain pathway have decreased excitability, will they be able to transmit painful stimuli? No. So the transmission of painful stimuli up the pain pathway is dampened, and that is the basic mechanism of action of opioid analgesics. Right. In addition to basically increase or decreasing cyclic AMP concentration and adenylyl cyclase activity, inhibiting voltage gated calcium channels, stimulating potassium rectifying potassium channels, they have certain other effects as well. For example, let us suppose again this is the lipid bilayer and this is the opioid receptor. As soon as a ligand binds to the G protein coupled receptor, it is not only going to inhibit adenylyl cyclase, stimulating the potassium channel and inhibiting the voltage gated calcium channel, but it also activates a group of enzymes which are known as BARC, which stands for beta adrenergic receptor kinase. Receptor kinase. And one of the BARC proteins is actually these BARC proteins belong to the group of enzymes known as G protein coupled receptor kinases. So it is just one type of GRK which is known as BARC. Now what BARC does is it specifically targets the ligand bound opioid receptor. So whenever the ligand binds, the activated receptor is going to stimulate BARC and it will identify which of the receptors has been ligand bound. So it identifies those receptors and phosphorylates those receptors. Once those receptors, the receptors which are bound with ligand, they get phosphorylated, then they can interact with the molecule which is known as beta arrestin 2. Now, as soon as the ligand bound opioid receptor, which has been phosphorylated by bark, interacts with beta arrestin 2, it gets internalized. So it is taken up inside the cell itself and therefore will no longer be able to bind to any more opioid ligands. So beta arrestin 2 promotes internalization of opioid receptors, right? And apart from this, opioid receptors can also undergo rapid agonistic mediated internalization by an endocytic pathway as well. As soon as the ligand binds, it right away gets endocytosed. But it depends on the type of ligand that binds to the receptors. For example, etorphin or enkephalins, they cause rapid internalization at the mu receptors. But morphine, on the other hand, has not been found to cause rapid internalization. What does it mean that the opioid receptor is undergoing internalization? Imagine a scenario where you have given a drug. Now, if this beta arrestin 2 pathway is all active and working very good, then more and more opioid receptors will get internalized. If more and more receptors are going to get internalized, will there be any receptors left on the surface for the drug to interact with? No. Then what will happen to the analgesic effect of that drug? It will decrease. And then you will have to use more or higher doses of that drug to produce the same clinical effect. And that is the very definition of tolerance. So beta arrestin 2 is involved in the development of tolerance, or rather internalization of opioid receptors has been involved in tolerance to drugs, certain addiction to opioid medications. And even not just these, but other untoward side effects of opioids have also been implicated by the beta arrestin 2 pathways. And from this very concept comes a very, very important phenomena of biased agonism. So what do we understand by biased agonism? Whenever an opioid receptor gets activated, so there are two things that are happening. First is there is this very, GI protein coupled receptor effector pathways happening, which is reducing adenylyl cyclase, stimulating potassium channels, inhibiting calcium channels, and eventually going to produce analgesia. Right? So when the G protein coupled receptor is activated, the GI protein coupled receptor, two things are going to happen, or rather, if when the opioid receptor gets activated, two things are happening. One is the GI protein pathway is getting activated, which is going to result in analgesia. The second is the beta arrestin 2 pathway is also simultaneously getting activated, which is going to result in all of the untoward effect of opioids, such as anti-analgesic effect or respiratory depression, constipation, euphoria, addiction, tolerance, etc., etc. The term biased agonism refers to, or the compounds that are biased agonists, they are only going to activate the GI pathway, and they are not going to activate the beta arrestin 2 pathway. So what does that mean? That means there will be better analgesia and fewer side effects. However, they are still under experimental stages. For example, in certain mice that have been genetically modified to not have any beta arrestin 2 in them genetically, they show that they have maintained analgesic effects of various opioids, but they do not have respiratory depression and constipation and all of the untoward side effects. Right? So there are certain experimental drugs such as TRV-130. Now this is a G protein biased mu opioid ligand. It has GI protein efficacy that is similar to that of morphine, but it has markedly reduced beta arrestin 2 recruitment, and that is why it produces greater analgesia than morphine, but produces less respiratory depression and less severe nausea. So biased agonism is a very novel concept and can be quite useful in the development of certain drugs which are going to take care of the side effects of opioids but still maintain the very much necessary analgesic component of opioids. So I think I will stop this lecture here, because if I continue to go on and on about opioids, this will be a never-ending lecture. But this is just the first part of the opioid series, and this was just meant to be like an introductory session. In the next lecture, we are going to talk about the supraspinal and the spinal mechanism of action of opioid analgesics, and the most importantly, the various pharmacodynamic effects of opioids in the body, whether it be in the central nervous system, its effects on mood, the reward center, cardiovascular system, respiratory system, endocrinological system, GI system, urological system, everything. And then in another lecture, we will be talking about pharmacokinetics and individual opioids and their specific uses. Thank you.